Hi, it's Neil Anglin, and today I'm going to talk to you about the cardiovascular examination. So as a cardiologist, there's various symptoms that we see commonly. So I'm going to go through these in detail now. As with any history, we usually start with an open question, and these are questions such as, what brings you to hospital today? Or how can I help you? And that usually allows the patient to sort of start a dialogue with you and then talk about exactly why they're coming to see you. Sometimes, however, patients need narrowing in, as this history can sometimes go on a tangent, and that's when you start asking close questions such as, tell me about the chest pain, or how long did the pain last for? So I'm going to go through the four most common cardiovascular symptoms that people present to a cardiologist with. The first symptom is chest pain. This is a very common symptom and can represent anything from someone having a heart attack to simple musculoskeletal chest pain. One of the things we're commonly taught at medical school is to use the acronym Socrates. And this doesn't have to be used, but it's a simple aid memoir on how to assess somebody with chest pain. So if we go through each letter individually, and we can talk about how you can use Socrates to assess chest pain. S stands for sight. So you want to ask your patient, where exactly is the chest pain? Is it across the chest? Is it in one particular spot? Is it in the back? Sometimes patients say they've got chest pain. Well, actually, they mean back pain. Is it in the upper chest, middle of the chest, lower chest? So sight is very important because it can give you clues to exactly what part of the body is being affected. O stands for onset. When did the pain come on? Was there something? Did something trigger the pain? So you want to know exactly the surroundings associated with the onset of the pain. C stands for character. So what kind of things can we describe the character of the pain like? Well, from a cardiovascular perspective, we get quite concerned if it's a crushing pain across the chest, and a pain that you can't really pinpoint, but is just a sensation across the chest. That could indicate cardiac ischemia. But there's other ways people describe pain as well. They sometimes describe it as a stabbing pain or a burning pain. Sometimes people could call it a sharp pain, or maybe even a tearing pain that maybe radiates somewhere else. But we'll come on to radiation in a second. So next is R. Does a pain radiate anywhere? So pains can start off somewhere, like for example the front of the chest, and it can radiate up to the neck, jaw, arms, or it can radiate through to the back, or radiate downwards, upwards, anywhere. So it's quite important to find out if the pain moves anywhere else. A stands for any associated symptoms. So symptoms you want to find out when someone gets chest pain. Is there anything else that happens with the chest pain? Common things to ask about is, do they feel nausea or sick? Do they feel short of breath? Do they feel palpitations coming on? Do they feel lightheaded? These are all important things to find out. Do they feel very warm? Do they feel like they're about to pass out? Just want to find out kind of, you can ask it as an open question initially, is there any other symptoms associated with your chest pain? And then you can start asking specific questions as previously stated. So T stands for time course. Did the pain just last for seconds? Was it just a twinge? Was it a pain that lasted all day or for several days? Is it a pain that's sort of coming on and off and acting intermittently? Or is it a pain that came on very severe for, say, 45 minutes or so, and now, that's the severity of the pain, and it's now left with a sort of slightly less duller pain that's ongoing? So it's quite important to find out the time course of the pain. Are there any exacerbating or relieving factors? So exacerbating factors typically for something like angina is a chest discomfort that occurs with exertion, and it's usually relieved by rest or perhaps a GTN spray. Other things that you can ask for if they're exacerbated or relieving, is it exacerbated by other symptoms such as palpitations, or is it exacerbated by laying flat or made worse by sitting forward? Is it made worse from bending in certain situations, or even pressing the chest? If it's pressing the chest, it's usually a musculoskeletal type pain. And lastly, the final S stands for severity. This is very, very subjective, but it's a good idea to find out how the patient experiences the pain. A lot of clinicians sometimes ask, on a scale of 1 to 10, how severe is the pain? So it just gives an indication on how, severely it's affecting the patient. Now let's move on to dyspnea. So dyspnea means shortness of breath, and there can be a number of causes for shortness of breath. That, it can be due to the heart, but it can also be due to respiratory causes. It can be due to blood disorders like anemia, or it can be due to just general unfitness. But if we stick with the cardiovascular causes for this video, what we're really interested in here is a couple of things when it comes to shortness of breath. Shortness of breath can be caused by impairment of the heart muscle, so heart failure, or it can also be caused by arrhythmias. So types of things you want to find out about the shortness of breath is things like, what brings on the shortness of breath? Is it on exertion? Shortness of breath can also be a symptom of cardiac ischemia, which is sometimes called an angina equivalent. So is it brought on by exertion? Is it, are you short of breath at rest? Is it certain activities that make you short of breath? Are you short of breath laying flat. That's called orthopnea and is associated with heart failure. Also, do you get up at night gasping for breath? That's called paroxysmal nocturnal dyspnea, another sign for heart failure. Is the shortness of breath been a gradual decline in your breathing, or is it a sudden onset shortness of breath? These are all things that should be elicted in the history and help hone down your differential diagnosis. The next symptom I want to talk about is palpitation. So this is a very common presentation to GPs and to cardiologists. So palpitations can mean a number of different things to different people, but essentially what a palpitation is the sensation of your heart beating. So the sensation of your heart beating can be a normal phenomenon. Some people can just feel their heart. Most people can't feel their heart, but they can feel it if they've done something exertional. So if you've run up a flight of stairs, or if you've just run a field or a marathon or something like that, you will feel your heart racing. What we're really interested in is sudden onset palpitation or palpitation symptoms when you shouldn't really be experiencing palpitation. So if a patient says to you, doctor, I'm experiencing palpitation, you really want to find out exactly, what it feels like for them. Questions you should be asking is, what were you doing at the time of the palpitation? Was it sudden onset? It'd be particularly interesting to find out if the palpitation occurred at rest. Is there something that triggered the palpitation? Is there something that relieved the palpitation? Did the palpitation suddenly start and suddenly stop? Did it, suddenly start and maybe fade away gradually? Did the heart feel like it was beating regularly or irregularly? We ask patients often to tap out their palpitation, and that way we can find out if it's very fast, very slow, or if it's irregular. And is the palpitation associated with other symptoms such as chest pain, lightheadedness, feeling that they're about to pass out? Did they actually pass out with the palpitation? So these are all really important questions to ask somebody with symptoms of palpitation. The final symptom I want to talk to you about today is syncope. Another presentation of the cardiologist, somebody who suddenly blacks out. So syncope, again, can be caused by a number of different things. Some can be benign in nature and some can be very serious. So when assessing syncope, you really want to find out the circumstances around the syncope. So it's usually very helpful if there's a witness that you can speak to, maybe a family member that saw that happen or a friend who could see exactly what happened. Because you can ask the patient, first of all, you want to find out with syncope, did they actually black out? Because some people say they've had syncope when they've actually had a fall and not actually completely blacked out. And, there's questions you can ask surrounding that. But cardiac syncope usually occurs when there's a sudden blackout with no real warning. Some people may feel palpitations slightly beforehand or a slight lightheadedness, but it's usually a blackout with no warning. And when patients recover, they're not usually confused or anything like that. So syncope can occur for non-cardiological reasons as well, such as seizures. So it's really good to get a collateral history from a witness to find out exactly what happened. Were there any seizure-type movements? Was there any urinary continence? Were patients post-ictal? And by that I mean, when they came around for the seizure, were they quite confused or acting strangely for a period of time after the blackout? Usually that's not quite cardiac. What's really important, did the blackout happen suddenly, or did it happen when you were laying down or sitting down? That's quite unusual to have a blackout when you're sitting or laying down. Did the blackout happen while driving? Obviously that's really important for driving considerations in the future. Another question to ask is, did the blackout happen when the patient suddenly stood up? That could be due to postural hypotension, or did the blackout happen when they were doing something such as trying to pass urine? That's something called micturition syncope, or if they were coughing. Sometimes when people cough, they can have a sudden drop in blood pressure, which is called cough syncope. Blackouts can also happen because of sudden drop in blood pressure called vasovagal syncope. This usually has a prodrome, you can get the history when patients say that they kind of felt a warm sensation coming on. They'd been perhaps standing for a long period of time. They feel a bit nausea, feel a bit sweating and feel a bit warm, and then suddenly they black out. This can happen to, for example, soldiers who've been standing for long periods of time, people in church who've also been standing for long periods of time in a hot room. So really trying to elicit the history of exactly what were the events surrounding the syncope is extremely useful to honing down that differential diagnosis. Now moving on to the past medical history, obviously if they've had a history of strokes, heart attacks in the past, or any heart arrhythmias, that's very important to know about. What I try and do with my cardiovascular history as well, especially when I'm reviewing somebody with chest pains, to find out if they've got any other cardiac ischemic risk factors. The cardiac risk factors I specifically ask for are history of hypertension, history of hypercholesterolemia, a history of diabetes, a family history of ischemic heart disease, and any history of smoking. Also ask if they have any kidney impairment, as that's another cardiovascular risk factor. In the social history, we also want to find out if they're a current smoker or an ex-smoker and how much alcohol they take on a weekly basis. Okay, and at the end of the consultation, it's always a good idea to summarize the consultation with the patient, because just in case there's any misunderstanding of the symptoms, or they may even throw in some extra symptoms they hadn't thought about earlier. So it's always good to summarize and make sure that the history that you've got from the patient is the history that is actually patient wants to give. So I'd like to thank you for watching this video. If you'd like to see more videos from me, I'd be grateful if you could like the video, subscribe, and click the notification button, and you'll be notified of any future videos. Thank you very much.